So throughout the entire MedMaster course, we're going to be giving you tips, tricks, and reference sheets and things to be able to answer the most essential NCLEX questions and to understand medications much more. What this lecture is intended to do is to kind of give you an overview of questions that most commonly appear on the NCLEX and side effects and things that are most often seen. Okay, so this isn't a comprehensive lecture by any means, but what this really is it just outlines some of the classes, some of the medications that most often, that like if you're going to see a medication on the NCLEX, there's a high probability that it will be one of these medications and it will be over one of these side effects, okay? So let's go ahead and dive in. The first medications we're going to talk about are going to be analgesics, and we're going to talk about three different ones here. We're going to talk about aspirin, NSAIDs, and morphine, okay? So with aspirin, a couple things to keep in mind here is that it actually works as a blood thinner, so we don't want to give aspirin with other anticoagulants if possible, okay? We don't want to thin out the blood too much and cause all the risk of bleeding and things like that. It's also important to stop taking before surgery. So this would be true with aspirin, with Plavix, and different medications like that if a patient's on a blood thinner, we want to avoid taking that prior to surgery, and that will depend based on the medication. But keep in mind that with aspirin, they're not going to, unless there's some sort of emergent situation, we would like our patient to be off aspirin prior to surgery. It's also important to not give to children, or not to give too much to children with a viral infection, because this can actually lead to Reyes syndrome. And we'll get into this more in different lectures and things, but remember aspirin, think Reyes syndrome. With NSAIDs, okay, NSAIDs are going to be contraindicated with GI ulcers. The reason for that is that NSAIDs can actually lead to GI bleeding, okay? So with patients that already have GI complications, we'll want to avoid NSAIDs. With morphine, we'll go into morphine in so much detail in other lectures, but morphine is going to be a CNS depressant. That's kind of how it works. So with CNS depression, you're thinking decreased respirations, decreased heart rate, etc. We will want to monitor our patients' respirations very closely and make sure that they're breathing at a sustainable rate, okay? Because morphine is going to further decrease that. If they're already breathing very low, blood pressure's low, heart rate's low, it'd be important to avoid morphine if possible.
Most people fail the NCLEX because they think they're ready. Then test day hits and they completely freeze. SimCLEX simulates the NCLEX, and NCLEX Readiness Score tells you how ready you are to take the NCLEX. Go to nursing.com to try SimCLEX and get your NCLEX Readiness Score now.
Okay, anticonvulsants. There's a lot of different anticonvulsants, but one that you're going to see most often is going to be Dilantin. Now, one of our other lectures, we're going to talk a little more about Dilantin and what the therapeutic levels are and things like that. But with one of the things that you'll see, well, there's two things you're going to see with Dilantin. It's going to be your therapeutic level, which we'll get into later and provide you a cheat sheet about that. And another thing is going to be that it can cause gingival hyperplasia or just gum hyperplasia. So it's important for them to have regular dental checkups, for them to use things like soft bristle toothbrush, to be very careful about flossing and things like that, because with this gingival hyperplasia, this can be lead to very severe mouth disorders. Okay, anti-inflammatories / steroids. So there's a lot of these. A lot of them are going to end in zone, deltazone, prednisone. These medications. So one thing that I'm going to try to stress with you a lot in different lectures is going to be when we're giving things like hormones and electrolyte replacements and things like that, we're giving them to replace something. Okay, so like with steroids, we're giving steroids because our adrenal glands are not producing steroids the way they need to be. Okay, so in situations of like Addison's disease, that's going to be adrenal insufficiency. And so what happens when we start giving these hormones back to these patients is it can result in the opposite end of the spectrum, which with steroid replacement, that's going to end up with like Cushing-like symptoms, the buffalo hump, and things like that. So with steroids, prednisone, deltazone, and different steroids, what can happen is we're giving it because of adrenal insufficiency. Once we start replacing that, it can get to the point of too much, which would end up in Cushing-like symptoms. So monitor for buffalo hump, monitor for Graves type disease, And this is true with all different kinds of hormone replacement type medications. And truly with any medication, once we're giving a medication because there's a problem, and what can happen is when we give too much of that medication, we can cause the opposite problem. So it's very important, and that's kind of what monitoring your patient and assessing your patient for these side effects is all about. Okay, but specifically with steroids, some of the things to keep in mind are that steroids can cause immunosuppression, they can cause hyperglycemia, and they can cause osteoporosis. So those are the three things I really want you to keep in mind with any steroid. And again, a lot of these will end in zone, S-O-N-E, is the immunosuppression, the hyperglycemia, and the osteoporosis. Okay, with anticoagulants, there's a couple anticoagulants that you really just have to know. This is true with nursing, and this is going to be true with nursing school, clinicals, nursing pharmacology in med-surg, etc. You just have to know heparin and warfarin. Okay, heparin and warfarin are two major anticoagulants. They work very differently, but they're both incredibly important to know. With heparin, we're going to be monitoring our aPTT, and our antidote is going to be protamine sulfate. With warfarin, we're going to be monitoring our PT and our INR, and we're looking for therapeutic levels with that depending on the patient's condition. Okay, we'll get into that later as well. And our antidote for warfarin is going to be vitamin K. Okay, so keep those two anticoagulants in mind as well as their antidotes. Very important. Okay, there's a couple anti-Parkinsonian drugs. For whatever reason, NCLEX really likes these anti-Parkinsonians. The two that you need to know are going to be benzotropine, and this benzotropine helps with extrapyramidal symptoms. So there isn't a cure for Parkinson's, and these drugs don't cure Parkinson's. What they do is they help with some of the symptoms, basically. They help control symptoms. So benzotropine helps with extrapyramidal symptoms. Those extrapyramidal symptoms will be like the lip smacking, the pill rolling. You know, when you hear that type of symptom in your patient, think Parkinson's automatically. The tongue and things like that. Another one is carbidopa-levodopa. This is a very important medication to know because it can actually cross the blood-brain barrier. And this is really effective in the absence of tremors. So those are two things to keep in mind with these two anti-Parkinsonian medications. With beta blockers. So beta blockers, we have a much longer video and we talk a lot about different beta blockers throughout this course. But keep in mind with beta blockers that a lot of times they're going to end with a suffix OL. It's important to not discontinue beta blockers abruptly, to generally discontinue them slowly, kind of educate your patient about that, and they can mask the signs of hypoglycemia. So if you have a patient who's on beta blockers, especially if they already have a history of diabetes or low blood sugars, that it's important to monitor their blood sugars, especially while in the hospital. Okay, so potassium supplements. Again, like I said with steroids, when we give supplements, it's important to keep in mind that we can cause the opposite problem. And we know with potassium, hypokalemia is incredibly dangerous, but hyperkalemia as well is incredibly dangerous for the heart. We can lead to lethal arrhythmias. So with potassium chloride, before giving a potassium chloride supplement, make sure you check the lab. And if your most recent potassium level is several days old, it would be prudent of you to draw a repeat potassium level just to see where you're at. If your potassium is already at 5.9 and you're about to give 40 milliequivalents of potassium, you could really run the risk of pushing your patient dangerously hyperkalemic. Okay, so monitor your labs, check your lab before you give it, and never give IV push. This medication burns and it needs to be given very slowly, so never give it IV push. And then use caution with potassium-sparing diuretics like spironolactone, because spironolactone and other potassium-sparing diuretics are going to preserve potassium and drive up our potassium level. So then as we're doing that, if we're also giving potassium supplements, we need to be careful there. Also, do not administer to patients with renal failure, and kind of just check with your physician first. If your patient's in like stage 3, 4, or 5 renal failure, just kind of check with your physician and see if that's something that they want to do. Some respiratory drugs to keep in mind. Again, remember, we're talking There's a lot of respiratory drugs. We're going to talk about a lot of them, but we're talking about medications that you just have to know these different side effects for. One of these is theophylline. So theophylline, I think I've probably only given theophylline once or twice. It's not an incredibly common medication. It's more common with neonates, with helping them to be able to breathe and things, but we don't really give it a lot with adults. But theophylline, one of the things to keep in mind is to monitor for tachycardia. It works like a stimulant, and it has similar effects of like caffeine. So think if you took a bunch of caffeine, you might have palpitations, you might be breathing, you might have jitters. So theophylline, think of it as if you had just taken a huge amount of caffeine, you just drank 10 Red Bulls or something, what it would do to you. So with your patients, you need to monitor for tachycardia after taking theophylline. Okay, cardiac glycosides. The cardiac glycoside you really need to keep in mind is digoxin, right? The first thing I want you to keep in mind is the importance of assessing the pulse for 60 seconds prior to administration. You want to check the pulse for a full minute and determine where the pulse is. And you don't want to give it if your pulse is under 60. Toxicity. This is a huge one for NCLEX. So what it will likely ask is a question, something about your patient experiencing yellow-green visual disturbances, and then you'll have to either identify that digoxin is the medication, that it's a side effect, etc. But this is a good sign that your patient might be experiencing digoxin toxicity. So you need to hold the medication, let the physician know that they're experiencing these yellow-green halos, and you'll probably draw a dig level and figure out where it's at, and then you can treat the patient as needed. Antihypertensive. So we're going to talk specifically just about this one, magnesium sulfate. Magnesium sulfate can be used with preeclampsia. Now remember, preeclampsia is like high blood pressure during pregnancy. I almost forgot the word pregnancy there for a second. But it's high blood pressure during pregnancy. So what we'll want to do is we're going to want to monitor deep tendon reflexes. We can actually lose deep tendon reflexes with magnesium sulfate. So you want to be very careful to monitor these deep tendon reflexes in these patients. And you also want to assess for respiratory depression. Mag sulfate can actually lead to respiratory depression. So you won't monitor that prior to the patient, getting into respiratory failure or anything like that. Another one here real quick is diuretics. So we're going to talk a lot about diuretics. And the biggest thing I want you to keep in mind with diuretics is going to be electrolyte levels, okay? With thiazide diuretics, loop diuretics, and other diuretics, one of the things you're going to be monitoring for most is going to be potassium wasting. These diuretics are going to rid the body of potassium, okay? So we're going to want to monitor our potassium levels, make sure we're not wasting or losing too much potassium. On the other hand, there's a class of medications known as potassium-sparing diuretics. The one that I want you to know is spironolactone. And what this does is it actually it doesn't waste that potassium. It keeps that potassium. We've talked about this just a second ago. But you're going to want to monitor your potassium level for the opposite effect of having too much potassium. Okay? Psychotropic drugs. There's a lot of psychotropic drugs to know. But the biggest ones you really want to keep in mind are going to be lithium, MAOIs, and disulfiram. So lithium, the biggest thing I want you to keep in mind is going to be that there's a therapeutic range for it. And it's 0.8 to 1.2. We'll talk about that a bit more, but once you want to be in that range in order for the drug to have the maximum effectiveness for your patient. You're also going to want to increase fluid intake when a patient is taking lithium. With MAOIs, monoamine oxidase inhibitors, the number one thing to keep in mind is going to be avoid foods that are high in tyramine. Now, prior to nursing school, you probably never even heard of tyramine. That's okay. Tyramine can be found in things like aged cheeses, wine, pickled meats, things like that. So just avoid foods that are high in tyramine. It can be detrimental to the patient if they're taking MAOIs and eating foods like this. Another thing to keep in mind is that with MAOIs and other psychotropics and stuff, you want to have about a 14-day window between discontinuing the MAOI and starting like the SSRI or something like that. So you really need that 14-day window where they've stopped the MAOI, wait about 2 weeks, and then they can start their SSRI or their other psychotropic or antidepressant or whatever. Another one is disulfiram. Disulfiram is an awesome drug. I like it because we give it to patients who, it's called anti-abuse. I think that's a really easy name to remember because it's like anti-abuse, anti-alcohol abuse. So we give it to patients who are alcoholics, try to help them stop drinking alcohol. So because of this, they need to avoid alcohol intake of all kinds. Because if they take alcohol while using disulfiram, they're going to have this massive vomiting, the massive sickness and everything, and that is to help them stop drinking. But because of that, they really have to avoid alcohol intake. They need to be careful with mouthwashes and over-the-counter cough suppressants because these can also create this disulfiram reaction. Maternity drugs. One maternity drug you need to know, you have to know, is oxytocin. So one big thing to keep in mind with oxytocin is what the purpose of oxytocin is to help the uterus contract. Okay, we're trying to create this contraction in the uterus to help kind of push the baby out. Now that's going to cause a whole lot of things we need to keep and watch with our baby, but also you need to keep in mind that you need to assess the uterus for tetanic contraction. What that is, that it can create this constant state of contraction where the muscle doesn't relax. Normally with contractions, you just think it's kind of like flexing your muscle. You flex your muscle, you relax it, it rests, and then it flexes again. What can happen with oxytocin or Pitocin is that the muscle can go into this constant state of contraction, which is very unhealthy for the patient. Okay, so keep that in mind. That's what you're assessing for with your patient taking oxytocin. Antifungal. We're just going to talk about one medication here. We're going to talk about amphotericin B. Some things to keep in mind here are assessed for hearing. This is true with like vancomycin, amphotericin. You're going to want to assess for ototoxicity, and the way to do that is going to be assess hearing, and that can happen. You can get like ringing in the ears, and that's how you'd kind of assess ototoxicity. So you want to give it IV piggyback slow over a couple hours. Monitor for renal damage. So when we talk about medications that can cause renal damage, one thing you'll want to keep in mind is that we need to increase fluid intake. If we increase fluid intake, we're going to help flush that through the kidneys and preserve kidney function. That's true when we give dyes to our patient for like CTs and things like that, as we want to increase fluid intake, flush the medication out of the kidneys. You also monitor your renal labs like BUN, creatinine clearance, etc., to monitor your renal function. You also will assess potassium levels again and cause renal damage. Okay, Anticoagulants. So we have a very great video lecture that Terang does and covers kind of your autonomic nervous system. But we'll talk really quickly about anticholinergics. What you need to keep in mind here is fight or flight system. You really need to understand the fight or flight system. If you don't understand that, we can't help you a ton. But once you understand the fight or flight system reaction, you can begin to understand anticholinergics much more. So what things like atropine are going to do is it's going to create like this fight or flight response, okay? When we're ready to fight, imagine a lion chasing you. When a lion chases you, you don't want your bowels to be flowing, so your bowel motility is going to slow down. Your eyes are going to dilate really large so you can see your surroundings. Your heart rate's going to go up. You're going to have bronchodilation so you can breathe and get in all the air you need to run away. So when we give these anticholinergics, we're going to have this fight or flight type response. So with atropine, okay, think anticholinergic. GI motility is going to slow. Again, we've talked about all these things. We just said this. Your eyes are going to dilate. So because of that, you're going to want to avoid in glaucoma patients. Heart rate's going to race. Bronchodilation is going to occur. So these are all things that you're going to watch in patients that are receiving atropine. One thing that we also do with patients, maybe at end-of-life type care, is we can give them atropine drops. And we'll give those atropine drops like under the tongue, 1 or 2 drops, and that's going to help with secretions. It's going to stop secretions, help them be able to breathe easier on their way out or as they're very sick or have just a tremendous amount of secretions. One thing that you'll see every year on my floor when we have new interns come in and stuff is they'll see these atropine drops and they'll put them right in the eye, okay? Yes, optometrists use this to dilate pupils for eye exams. When we give it in an ICU type setting, we're not giving it for the eyes. So what'll happen is they'll put it in the eyes. These patients' eyes will go to like a 9 or a 10, just so massively dilated. But that's not what we're giving it for in the ICU. In the ICU, we're giving it to stop these secretions, okay? So that's atropine. Oncology medications. So just in general, this is just a general rule of thumb. When you're giving oncology medications, you want to use extreme caution. Always wear a glove and mask while mixing and administering. And you should not do this unless you're really certified to give oncology medications. Anti-gout medications. When you hear the word allopurinol, think anti-gout. Okay, there's multiple gout medications, DMARDs and everything, but the one we're going to talk about is allopurinol. With allopurinol also, you want to avoid organ meats. Now, these organ meats are what may have led to the gout, this purine, this high purine diet. So with allopurinol, we're going to avoid organ meats. We're going to avoid more purine. The patient will have increased urine output because we're having them increase their urine intake, okay? So that's kind of what you want to keep in mind with allopurinol. Okay, last slide here. I want to talk about the difference between myotics and mydriatics. Okay, myotics and mydriatics. Okay, these are both ophthalmic medications. One to constrict the pupils, one to dilate the pupils. But one we use with glaucoma, one we want to avoid with glaucoma, okay? Myotics constrict. Okay, myotic constrict. Used with glaucoma, and they help increase the outflow of aqueous humor. So that can help with glaucoma, that helps relieve that pressure in the eyeball, and that helps a patient relieve that pain and be able to see a little bit better. Mydriatics, these dilate the pupil, so we're going to avoid with glaucoma because it can increase intraocular pressure. If we increase that intraocular pressure, we run the risk of causing more symptoms of glaucoma. So myotics, constrict, used for glaucoma. Mydriatics, dilate, avoid with glaucoma. Okay, that's really kind of it for this lecture. These are just highly likely medications that you could see on exams and on the NCLEX. If you have any questions, be sure to let us know, but I think this video will greatly assist you.
Hope is not a strategy. You either know you're going to pass or you think and hope that you are. NCLEX simulates the NCLEX for you, and your NCLEX Ready Score tells you if you are ready to take the NCLEX and pass right now. Head over to nursing.com to get your nursing survival package and NCLEX Ready Score now.